Good evening to everyone. It's a great pleasure to be part of this amazing ISOC education course talking about the post-cesarean delivery syndrome. We know that nowadays cesarean section is the most commonly performed procedure in the world. We have been assisting to an incredible rise in cesarean section rates, unfortunately, and unfortunately, parallel to this, also the reported rate of complications associated with cesarean section have been rising. We know that in 60% of women who had the cesarean delivery, it's possible to find at ultrasound the evidence of a niche in their uterus. And unfortunately, in 25% of all women, we will find a large defect with a residual myometrial thickness of less than 3 millimeters. The majority of niches, most of them will be completely asymptomatic, but unfortunately, in 30 to 40% of women, there will be symptoms like spotting, dysmenorrhea, chronic pelvic pain, and so on. So as we will see in a while, a symptomatic niche can have a profound, deep impact on women's quality of life. Several terms have been used in the literature to describe the finding of a niche, and today, the association of words cesarean scar defect, so CSD, should be used to name all the anomalies characterized by a defect within the myometrium as a result of defective healing after a cesarean section. So another very important aspect to take into account is to make a distinction between a pure sonographic finding of a niche and the constellation of associated symptoms related to it. In these studies, several symptoms associated with the presence of a niche have been reported. So prolonged menses is the most reported symptom in women with a cesarean scar defect. Also spotting is very uncommonly described, ranging from 20 to 60% of women with a cesarean scar defects. Also, chronic pelvic pain is reported in 4 to 30% of women with a cesarean scar defect in association with abnormal uterine bleeding and dysmenorrhea. Two factors are very important in the assessment of these women, as they can increase the risk of spotting, bleeding, and prolonged menses. And these factors are the higher volume of the niche and the smaller residual myometrial thickness. So the smaller residual myometrial thickness is very important, as it is the volume of the niche. In studying, assessing the quality of life of women with a cesarean scar defect, we found 6 studies in this interesting systematic review. Important outcomes that were negatively correlated with the presence of a niche were the participation in leisure activities and the self-esteem. So we see that the presence of a niche can have a profound impact on women's life. Also, interestingly, women who had a laparoscopic niche resection had an improvement in the quality of life. This was also true for women who had a surgical intervention for the repair of a niche as compared to women who had hormonal treatments. Given the wide heterogeneity present in the literature in the definition of the condition and also in the description of symptoms that are part of this condition, in this study, the authors performed a Delphi procedure involving the main international expert in the treatment and diagnosis of niches in order to reach consensus on the definition of this clinical condition that constitute a symptomatic niche, and also to agree on the diagnostic criteria and to uniform the nomenclature for this condition. So international experts were asked to reply to some questions related to 6 thematic areas, including the nomenclature, the symptoms, and the conditions needed to exclude and to confirm the diagnosis of a cesarean scar disorder. So, first of all the experts agreed on the following statement, that it is important to differentiate between a simple sonographic finding of a niche and a condition caused by niche-related symptoms that affect the quality of life. Another agreement was made on the sonographic finding that should be found and how should be defined. And authors suggested, the experts suggested that this has to be done in accordance to the previous suggestions of the European Niche Task Force. So the niche should be described as an indentation at the side of the cesarean delivery scar with a depth of at least 2 millimeters. Regarding the nomenclature, among all the possible options discussed, the term cesarean scar disorder was the preferred term to describe a niche that caused symptoms. This term was chosen as it implies the origin of the symptoms, and at the same time, it stresses the concept that it is an abnormal condition. The symptoms. So experts agreed on the fact that to define this condition, we need at least one primary or at least two secondary symptoms in association with the sonographic finding of a niche. Among primary symptoms, we have postmenstrual spotting, pain during uterine bleeding, technical issues with catheter insection during embryo transfer, and secondary unexplained infertility associated with the evidence of intrauterine fluid. Among secondary symptoms, we have dyspareunia, abnormal vaginal discharge, chronic pelvic pain, and so on. So these symptoms are needed, one primary or at least two secondary, in association with a sonographic finding of a niche to have the diagnosis of cesarean scar disorder. Two very important aspects are also related to the diagnostic criteria that should be met in order to have a diagnosis, and about the conditions that are needed to be excluded before the diagnosis. So we need to have at least 3 regular menstrual cycles after cesarean delivery to make the diagnosis. The woman have to be premenopausal. The symptoms should start after a cesarean delivery, or at least should worsen significantly after cesarean delivery. And also the expert agreed on the fact that a patient can be cured from a symptomatic niche, even if this doesn't imply that all the niches should be treated. Conditions to exclude are cervical dysplasia, vaginal or uterine infections, other uterine intracavitary pathology, and other causes of postmenstrual spotting. Anovulatory cycles also needs to be excluded before a diagnosis can be made. So we asked to the literature why we see those symptoms associated with the niche. And from pathology reports, there are several changes that are frequently reported together with the niche. For example, congested endometrium, lymphocytic infiltration, capillary dilatation, and so on are very frequently reported. In addition to this, endometriosis. Endometriosis foci have been found in 20 to 27% of women at the deepest part of the cesarean scar defect. So those endometriotic glands present in the myometrium that covers the surgical defects can be responsible for pain and for dysmenorrhea, but they can also be responsible for blood retention due to abnormal bleeding from the endometriotic glands present at the level of the scar. Another very frequently reported finding at pathology reports is the retention of blood. Retention of blood can be due to 2 different problems. The first one is the hypervascularization that can be seen in the bottom of the scar, as you can see in this hysteroscopic view of the scar. And also, retention of blood can arise from inadequate myometrial contractility at the level of the scar. In particular, the inability of the myometrium covering the defect to provide enough contractility to expel the blood deriving from menstruation can cause the accumulation of blood and retention of blood at the level of the cesarean scar defect. Also, there is a significant decrease in the muscular density of the myometrium covering the scar that can be responsible to these defective contractions and so to retention of blood. When we look at the anatomopathology reports, when we look at these 2 different hysterectomy specimens of women with a scarred uterus, we can see that there are profound differences between the uterus on the left with a correct healing of the scar and the uterus on the right with a defective healing showing a cesarean scar defect. So in the uterus on the left, the scar is just seen as a very tiny shallow depression that is covered by a thick myometrium on the top. While when we look at the uterus on the right, we see that the scar area is characterized by the presence of a deeper anterior defect, which is covered just by a very thin layer of myometrium. When we look at the microscope after actin immunostaining in order to highlight the muscular density in the scar area, in uterus on the left, you see that the muscular density of the myometrium is very similar to the adjacent healthy myometrium, while in the uterus on the right, we have a muscular density which is very much decreased as compared to adjacent area. So the active immunostating has almost no color in the area of the very thin myometrium covering the scar area in this uterus. So this thin and this decreased muscular density have to be taken into account also when counseling women about the possibility of surgical repair, as this can be a problem when approaching surgically those scars. Impaired fertility is also a frequently reported adverse outcome in women with a cesarean scar defect, ranging from 4 to 20%. Several mechanisms have been suggested to explain the impaired fertility in this population of women. In particular, the presence of blood at the level of the scar defect and in the uterine cavity might prevent the penetration of the sperm cells inside the uterine cavity, and also the flow of bloody fluid or bleeding from the cesarean scar defect can interfere with the implantation in the uterine cavity. Another possible mechanism is the excess of iron deriving from the hemoglobin degradation in the uterine cavity. So excess of iron can be embryotoxic, and also it can impair endometrial receptivity and also interfere with the uterine microbiota. Two very worrying outcomes that have been reported in women with a cesarean scar disorder are the uterine rupture and PIS, placenta accreta spectrum. So 3 out of 3 studies reporting on PIS found a weak positive correlation between a cesarean scar defect and PIS. Also, larger cesarean scar defects have been reported in association with dehiscence or uterine rupture in subsequent pregnancies with a high odds ratio of almost 12. So how do we define larger cesarean scar defects? This is often done by using the residual myometrial thickness using different cutoffs. So usually a cutoff of less than 2.5 millimeters is used for women with 1 cesarean delivery, or less than 2.3 millimeters for women with at least 2 cesarean deliveries. So in population of women with a large defect, the uterine dehiscence at cesarean delivery and the uterine rupture at cesarean delivery have been reported more frequently. Also, another interesting finding is that women who underwent laparoscopic resection of the niche have a better outcome in subsequent pregnancies. So when comparing women who had the laparoscopic resection to women who had an expectant management, pregnancy outcomes were better in terms of residual myometrial thickness throughout all the pregnancy, and also in terms of reduced rate of dehiscence found at cesarean delivery. So what can we offer to a woman complaining of symptoms related to a cesarean scar defect? The medical management is the first approach in women who have no longer desire to conceive, and also who have no contraindications to hormone treatment or therapy. When this is not possible, a surgical management can be suggested. Hysteroscopic resection is a good strategy, but we have to keep in mind that this is a resection of the niche and is not a proper repair. The limiting factor to this procedure is a reduced residual myometrial thickness, given the risk of uterine rupture during the procedure. Laparoscopic repair is a proper repair. During laparoscopic repair, it's also possible to correct the presence of adhesions, for example, and the cutoff of the residual myometrial thickness to suggest a laparoscopic repair is usually of less than 3 millimeters. The vaginal approach has also been reported with a lower rate of complication after vaginal repair. And finally, when all the other approaches did not succeed in controlling the symptoms, hysterectomy can be offered to the woman. So to conclude, we now know that a broad range of symptoms, including spotting, abnormal bleeding, chronic pelvic pain, and poor reproductive outcomes can develop after a cesarean delivery. Long-term complications, including the possible development of a cesarean scar disorder, should be part of the counseling when a cesarean section is discussed with a woman. Cesarean scar disorder has to be suspected in women presenting with spotting, dysmenorrhea, pelvic pain, or infertility with a history of a prior cesarean section. Also, the diagnosis should include transvaginal evaluation of the scar with adequate measurements. And finally, we know that asymptomatic women should not be treated, or not all the symptomatic niches should be treated, but in women who still wish to conceive, they should require a surgical repair of the scar area in order to decrease the risk of uterine rupture of the dehiscence in subsequent pregnancies. Thank you so much for your attention. If you have any questions, you are more than welcome. Thank you.